We are live.
Live? Okay. Hi, team members. Please check. We are live. Okay. I hope you can hear me. Please confirm in our WhatsApp group. Can you hear me? We can see you and hear you. Thanks, BP, for the confirmation. Other team members, can you please check and let us know? Can hear you. Thanks, Ramesh. Thanks, Muthu. Thanks, Suresh, for the confirmation. So, other team members, I'll request, please confirm. I think if 4 or 5 places we are getting yes, so all other places also, it's fine, right? So you can see, I'll request each team members, right? So at 7:56, we will go live again, okay? And on that time, please refresh the page before the start. Yeah, right now we are not sharing any slide, okay? Can we share the slide from here? आप वहां से share करो ना slide करने बोलो. Just a minute, we are just asking them to share the slide. Just give me a second. Slides देखो. Can you see the slides? Please confirm. Can you see the slides now? We are changing the slide. Can you see the slides? Please confirm. Yes, slides are visible. Okay. Okay, all right. So, Ashmi, so what we can do now, that's fine. I think I'm getting a response from my team. Okay, so I think majority of the people, they are able to see the slides and they can hear it also. Okay. So I will send you WhatsApp. Okay. So most probably 7:55 we will go live, or 7:56 something. Yeah.
Okay, fine.
Yeah. Thank you. Thank you so much. Yeah.
Thank you. Okay.
Yeah, it is on. Everything is on. Good evening, everyone. It's my privilege to warmly welcome all the distinguished doctors, respected guests, panelists, and participants to PVC Global Connect webcast on conference organized by Bayer and managed by Mervyn Solution. So now I would like to invite Dr. Ashish Gaude. He is Medical Director, Bayer South Asia, for leading the program more further. So now it's over to you, sir. Sure.
Good evening, respected sirs and madams. First of all, thank you so much for being here. I know it's a working day, so for many of you, navigating through this steady traffic and be here at 7:30 has been a task. So first of all, on behalf of Bayer, we welcome all of you and we would like to thank all of you for being there. Before starting with the meeting, I would just like to take this opportunity of our commitment of Bayer to the opthal. So we started with this journey long time back. I think all of you have been associated with us for almost a decade. We launched ILIA 2MG in 2016, and since then we have been trying to do those kind of scientific meetings which probably can enrich the knowledge of everyone, and we also can learn from your experience. That has been our endeavor. We obviously are looking forward to even bringing the newer innovative assets to the market. Especially, I know all of you are eagerly waiting for the Aflipercept HD or the ILIA HD, which we will do it in some time. And I also wanted to share that though it's very much in the initial stages, we are trying to extend our commitment to the ophthalmology by having different partnerships with the innovation companies. We are right now working with one of the company where we can try to bring an innovative molecule in the market, which probably can be used for the treatment of diabetic retinopathy, DR, as well as it can also be used for the treatment of glaucoma, of course, but that's in a very initial stages of research. So it will take few years to come in the market. Coming to this today's session, it's really a privilege for us to have Dr. Tan has been there, but along with that, Dr. Lalit Verma sir, he is on the way and he should be there at any given point of time. But in the meantime, I would like to introduce our co-chair, Brigadier Dr. S.K. Sharma sir. I mean, S.K. Mishra sir. Most of you are basically very familiar with sir, but just to give some accolades, sir has been associated as a head of the department for these ophthalmology with the prestigious RNR Institute. That's the main institute that we have, Army Hospital in New Delhi. And sir has been one of the most decorated medical officers in the history of the Indian Armed Medical Forces. With this brief introduction, I would like to call upon Dr. S.K. Mishra sir to this dais so that he can take this session ahead. Thank you, sir.
Hello. Thank you so much for the introduction. We eagerly await the arrival of Dr. Professor Lalit Verma. But in the meantime, I'm going to introduce Dr. Kelvin Teo. He's our chief guest speaker today. He's a world-class retina specialist from Singapore and has over 15 years of experience. He's a leading expert in treating complex retinal diseases and has done his medical degree from London and PhD from Australia. He has 2 prestigious fellowship in medical retina from Singapore National Eye Center and Sydney Eye Hospital, has extensive global exposure and has done many pioneering cutting edge research. He has done Singapore's very first advanced gene and dry AMD therapy. He has published over 150 papers, research papers, and won major awards for his research. He has also helped Singapore's national eye screening program and currently works at Advanced Eye Clinic and Surgery and the famous Mount Elizabeth Hospital. So without wasting much time, may I request Dr. Kelvin Teo. He's going to speak on PCV outcomes, integrating diagnosis, APVRS recommendation, and real-world evidence from APAC region. Dr. Kelvin.
Very good evening to everybody. Really my privilege to be speaking with all of you this evening. Been to India many times and I really enjoy my time here. And this evening, I'm going to talk about PCV. I think PCV is a condition or a subtype of neovascular AMD that we're all very familiar with in this part of the world. I know that here in India, you see many PCV patients as well. And really just to give you a brief journey through PCV, how we treat it, how we diagnose it, and maybe talk a little bit on some of the newer agents that are available. So some standard disclaimers here. So I'll go through a little bit about the prevalence of PCV, how we diagnose PCV, some treatment guidelines and the latest guidelines from APVRS. We'll talk a little bit about aflibercept and some future agents that we have in the pipeline. So we know that PCV is much more prevalent in Asian populations. The proportions here, 60 to 70%. In my practice, I probably see a little bit more PCV because my colleagues tend to refer these cases to me. And of course, in the Caucasian population, probably sitting at about 30% is about right. And the idea here, or the gray area here really is that in Caucasian population, maybe not many of these practices do indocyanine green to make the diagnosis. Which brings me to my next point. So we know from Everest and some of the colleagues from Japan, the use of ICGA to diagnose PCV. And I'm curious to know how many here in the room still have ICGA routinely. Excellent, fantastic. In Singapore, a lot of practices are starting to stop ICGA. And in fact, a lot of practices are starting to stop doing angiograms completely. I do a lot of angiograms, and ICGA to me still is extremely important. So I put up some pictures here, very classic looking images of PCV polypoidal. And of course the video, can I run the video? Let's see. There we go. Of course, if you have video angiography, you can see the pulsatile polyp there. You can see that pulsing lesion there that is very typical of polypoidal. So can we use alternative imaging modalities to diagnose PCV without ICGA? Yes, we probably can. And I would say that this serves as a very good guide to diagnosing PCV, but ICG is still really the gold standard. But because we felt that as more and more practices moved away from doing angiography, we came up with this paper back in 2020 to look at some of the other imaging modalities to try to make that diagnosis. And we screened through the literature that was available at that point in time, and we decided on these top imaging features that help us evaluate non-ICG diagnosis of PCV. The green ones are major criteria, we call them. The orange one were minor criteria, and the red ones really didn't matter to the accuracy of diagnosis. So our conclusion was that a combination of any top 3 major criteria and any one of the minor criteria would give you a very good ability to differentiate PCV from non-PCV eyes. And if you only had an OCT machine, 2 out of 3 essentially OCT signs could again give you a very decent ability to differentiate PCV and non-PCV. So it's a sub-RPE ring-like lesion. You can see that on your right-hand side. You can see sub-RPE. You can see on-fast OCT complex elevation. So this is we're looking at your OCT images from the top down, not on a cross section, but top down. And you'd see these very craggly edged complex elevations looking at you. I'll show you some examples in a second. Of course, sharp peak PEDs. And 2 out of any of these 3 would give you an AUC of about 0.8 0.84 to 0.89. So the best way to look at this is really through examples. I like cases, so we'll go through a lot of cases this evening. So here you can see a peaked PED. You can see the sub-RPE ring. And again, if you're looking at your OCT scan from an on-fast perspective, you see these complex RPE elevations. And really, they consist of the branching vascular network as well as the polypoidal lesion itself. And if you look at the ICG for this particular patient, you see the polyp lesion right there. So let's look at another example here. You can see, again, these things don't stop at the right place. So the sub-RPE ring, there's a double layer sign as well. And you can see small peak PEDs. Again, if you look at the on-fast image, you can see the complex RPE elevations. And again, on ICG, you can see the polyp right there. Let's look at the ICG of this particular patient. You see a hotspot, so you may be forgiven to think that this was a polypoidal lesion. But if you look at the OCT scan itself, you don't see any of those features I described. So no sharp peak, no ring lesion. And of course, this is a type 3 or RAP lesion. So not only is it able to help you make the diagnosis, but also helps you to differentiate things that might look like a PCV on ICG. Does OCTA help? So if you have the luxury of having an OCTA machine with your OCT scanners, you may be tempted to do OCTA. And here in this particular paper back in 2014, so this is how long the technology has been around. So 2014, when we scanned eyes with polypoidal lesions from an on-fast perspective, you can see that the sensitivity actually was pretty bad using OCTA on fast to diagnose PCV, but specificity was quite good. This particular paper also looked at using OCT itself, and essentially it was unable to differentiate clearly whether there was a polypoidal lesion or not. So we fast forward that 5 years, and this was a paper from our group. And the question was, we always look at OCTA on fast, but can we look at it cross-sectionally, and does it provide more data? And it does, because if you look at the cross-sectional OCT, if you look at where that sharp peak was, where that ring lesion was, you start to see some flow signal. And with that additional information, it then gives you a much better accuracy in differentiating PCV from non-PCV patients. And we fast forward to today. So this is a patient of mine, and this OCTA is captured on a NIDAC RS1. This particular platform is a prototype, which NIDAC has very kindly offered to me. And it gives an excellent view on fast of the entire branching vascular network and the polypoidal lesion, as well as on the cross-sectional OCT. You can see the flow signal very clearly within the peaked PED itself. And of course, on ICG, you can see that polyp lesion as well. So what can we do with this OCTA technology? So let's move it forwards. We can begin to reconstruct with OCTA in all dimensions of the flow signal. And we can create essentially three-dimensional models of what these polypoidal lesions might look like. So you can see here, this is some of the work that I did together with my imaging specialist in the university. So you can see the elevation of the polypoidal lesion sitting above the branching vascular network. So this is reconstructed from high density OCT angiography. You can then put these, you can then overlay the RPE layer, so it's in green, the network itself in red. And essentially what we see as the ring within the OCT is that blue bit in the middle. So it's actually a hollow bit of fluid within the polypoidal lesion itself. So it really gives a good appreciation of the entire lesion itself. So we can diagnose PCV, of course, gold standard ICGA. We can use some OCT clues to figure out whether it is PCV or it's non-PCV. We can look at more advanced imaging modalities like OCT angiography, which takes us to the next point, treatment and management. So because PCV was becoming a much more popular subtype, APVRS decided to update the guidelines on how to treat PCV, and this was in 2025. So in fact, our OCT non-ICG criteria made it to these guidelines. So you can use OCT and non-ICG criteria to have a very high level of suspicion of PCV. And once that confirmation is made, you then start your treatment. If you had large submacular hemorrhage or this was an extrafoveal polyp lesion, you could do some laser, you could do some pneumatic displacement. But if it was something that was fovea involving with the absence of large submacular hemorrhage, you could start anti-VEGF monotherapy or combination with PDT. How many still do PDT? No more PDT in India. I get this a lot. No more PDT in India. Not available. So anti-VEGF monotherapy then. And with anti-VEGF monotherapy, really the guideline was to monitor response with OCT plus minus angiography. We talk a little bit about polyp regression and stabilization of subretinal fluid, and then gradually being able to extend that treatment interval. Or if there's persistence or recurrent disease activity, then to shorten, change an agent or try and get your hands on some PDT if you could. But essentially, the take-home message from the guidelines was that monotherapy with anti-VEGF is still very effective in most, if not all, cases of PCV. And of course, you know, a thorough different agents that we can use now to explore the treatment with PCV. But I can tell you that the most extensive evidence for PCV treatment still comes with the use of aflibercept. A quick summary here of all the agents that you have available, and I'm sure many of you are, in fact, potentially more familiar with one of particular agent compared to me. I don't have any brolucizumab in Singapore, and but you know, we have all the other agents available as well. I like to drive home the point that ultimately when we treat our patients with neovascular AMD, be it PCV, be it type 3, type 1, vision still remains the most important outcome for me and for the patients as well. So while we use anatomy to help us decide on how we treat and what treatment strategies we use, ultimately vision is still key because patients want to see. In PCV, we have the additional anatomical outcome of polyp regression because we have a particular anatomy there that's special, right? And that becomes a little bit of a surrogate for us to tailor our treatment strategies. And if you look at a lot of essentially trials that were done around the subtype of PCV, a lot of them will deal with polyp regression, polyp inactivity, but ultimately, really, it's still about mean change in BCVA. And as you can see here in VIEW trials and in PLANET trials, the number of letters gained was very, very nice. You had good two-line gains in vision using aflibercept 2 milligram. And you can see that also within the PLANET trial, very few patients required to have a rescue PDT, if you remember back all those years, and a very respectable rate of polyp closure and polyp inactivity as well. Lots and lots of real-world data has come up regarding the treatment of PCV with aflibercept 2 milligram. You can see good gains in BCVA. You can see as well good rates of polyp lesion regression. PLANET gave us the ability to see PCV over 2 years. And again, you can see a reduced number of injections with good gains in vision up to 2 years. And very recently, we published 6-year data outcomes of PCV in the PLANET study. And we were very fair as well. We also published 6-year outcomes with Everest. So there are the 2 papers out there. So there's Everest 6-year data, there's PLANET 6-year data. And in the 6-year data for PLANET, you can see that a very respectable proportion of patients gained 10 letters. Almost half had more than 70 letters. And polyp lesion closure rate, this is interesting. So at 2 years, it's at about 35%. At 6 years, almost 70% had polyp lesion closure. If you compare that to the Everest 6-year data, it was about 30 and about 40% at 6 years. So did the starting agent make a difference? I don't know, but the long-term data with 6 years with aflibercept showed good closure at 6 years at 70%. With long-term data, it's always very tricky because once they leave a trial, they get treated in real-world clinical settings. And the number of injections, as you can see, averaged about 2 injections per year. We thought that this was really massively undertreated. So we looked at a subgroup of patients that were in reimbursed markets, so Taiwan, Australia. And in these reimbursed markets, you see a much higher number of injections given, so 9 versus 6.1. And in these markets where we thought that these patients were treated a little bit more appropriately, there was a greater number of increase in mean BCVA, and central subfield thickness was significantly lower in these patients as well. So really quick summary here of what we learned from 6-year data. And I believe many of you are treating your patients out to 6, even 10 years. And, really, I think with this particular study, we found that good early treatment really helped with the longer term outcomes. So perhaps it's worthwhile to address the elephant in the room. So we have Planet data about PCV. We also have SARWIN. So SARWIN, for those that don't know, is a trial of faricimab in PCV-specific patients. This was a single-arm, non-randomized, so there was no comparator arm in SARWIN. So they only treated with faricimab. They followed treatment regimen that's very similar to TENAYA and LUCENT. They had 4 loading doses. So remember, in Planet, there were 3. In SARWIN, the 4 loading doses of faricimab. They were then assessed after the 4 loading to see whether they could go into the 12, 8, 12, or 16 arms extensions. In Planet, of course, we had a rescue PDT arm. Baseline, probably a little bit different in the 2 trials. And also how these patients were assessed to have PCV was also a little bit different. So in SARWIN, 77% was reading center diagnosed PCV. In Planet, almost 95, 96% were PCV diagnosed. And ultimately, it's very difficult to make a comparison between the 2 trials. And they look at different things, right? And ultimately, I would drive home the point again that we have probably the longest amount of good data with aflibercept 2 mg with treating PCV or AMD for that matter. Lots of other small trials that look at comparing aflibercept versus faricimab. So here, a trial from Japan looking at essentially the first 3 loading doses. You can see that there was a significant difference, better vision with use of aflibercept in terms of vision. And also, if you look at anatomical outcomes in terms of fluid and also with polyp resolution. There we go. So this was a very small head-to-head trial, nonetheless, still a head-to-head trial with aflibercept versus faricimab with treating PCV. And what it shows here, aflibercept was more likely to deal with your disease activity after 3 loading injections. So lots of trial data, lots of real-world data. I want to show you some of my own data. So we started faricimab maybe 6 years ago now. I believe it's about the same in India. And what we found, of course, with the new molecule, we're very excited. We wanted to try it on all our patients. But what we found was that when we switched some patients that were on aflibercept 2 mg, we had a little bit of paradoxical response. I'm not sure whether anybody in the audience has the same experience. I'm going to go through some of the cases. So in this case here, 3 previous ranibizumab, 4-week intervals, you see a bit of subretinal fluid, you see a small PED, there's a PCV case. All these cases are all PCV cases. So we switched to faricimab, gave 2 faricimab injections, and this is what happened. So you have a bit of resolution of the SRF, but there's still some subretinal hyperreflective material. And what you notice now is that you have a much larger PED inferior. So I've put up the baseline scan, prior imaging. This one is 4 weeks post faricimab. After 2 shots, you're getting this little larger PED in the inferior. And then because of this, and because that PED there wasn't looking very friendly, we were worried of submacular hemorrhage. We decided to switch this patient back to aflibercept. And after 2 mg aflibercept, you see that PED reducing very markedly. And I'll show you two more cases here. So first case on the top, lots of aflibercept injections, more than 10. You're still getting that suboptimal response, a little bit of SRF. We gave 3 faricimab in this case, and again, you can see that paradoxical response. Likewise, for the bottom image, also quite a number of aflibercept injections. Again, 5 weeks post 4 faricimab injections. Again, you're seeing that larger PED. You're getting some response with the subretinal fluid, but you're seeing that larger PED. And those large PEDs, in my experience with PCV, is always a worrying sign because polypoidal lesions sit below the RPE. And when you have activity, that's where fluid is going to start accumulating first. So when I see adding increasing PED in PCV patients, it's always extremely worrying for me. So then in this case here, these cases here, we decided to switch them back to 2 milligrams. And you can see, again, those PEDs flattening out nicely and much, much better disease control in terms of the anatomy. I'm going to show you one more case here. So this one's a 74-year-old gentleman, treatment naive. It's a type 1 CNV, and he was treated with some aflibercept. Looked very good. So you've got a nice flat, dry retina. You've got an OCTA with, just that matured trunk vessel. And essentially, this is what happened after 4-week intervals. So remember, he had 3 Eylea 2 milligrams 4 weekly. He looked very quiet. I decided, because I had my hands on a new drug, I would change him to faricimab. And 4 weeks later, his neovascular network actually increased in size, and he's getting a sliver of subretinal fluid now. And because I had an even newer drug, I gave him an 8 milligram. And 4 weeks later, you can see that shrinking of that neovascular network. Again, disease activity are looking a lot better. And we can discuss why this is happening. I have got my theories and be happy to listen and hear what people think. But in my experience, I am seeing some paradoxical response with some of the newer agents. Let's look at standard treatment. Okay, let's get at standard PCV eyes. And we had the privilege of running the Planet trial in Singapore as well. So I thought I'd dig up some of these old patients and I'll show them because they have some long-term follow-up. So first patient in Planet study, monotherapy, had sham PDT. First year, 9 Eylea injections, 1 sham PDT, gained 20 letters, doing very, very well. 615 vision to 6.6. This was using, Planet was 2 milligram sham PDT, so didn't actually have PDT done. Second Planet patient here, monotherapy arm, so had a chance for rescue, but didn't need the rescue. Baseline vision 630, you can see again, excellent response, polyps going away on ICG. By the end of first year, really looking very, very quiet. And essentially after, if you remember, after the primary outcome in Planet, patients were allowed to have treat and extend. So I'm going to show you some treat and extend cases here. So this was a traditional 2-weekly treat and extend. So all the way up to year 3, again, looking extremely quiet, and this patient was able to last the entire time. And of course, we can do 4-week extensions with extended intervals. Again, this patient up to week 52, doing very, very well with few number of injections, 7 injections over 1 year. And with a lot of PCV trials, you're going to start hearing about this concept of inactive polyps or polyp lesion activity, right? And so what essentially that means is you're seeing persistent polyps on ICGA, but no fluid around the polyp lesion itself. So what do you do with these cases? Do you try and chase these polyps down? Do you try to close them? And so this is what sometimes I still do. So I treat with PDT because I have PDT. But an alternative, if you don't have PDT, is perhaps you can increase the intensity of your anti-VEGF treatment regimen. So this is a trial that we did where we personalized the treat and extend. So after 3 months, after the first 3 loading injections, we repeated ICG. If polyp was still active, in the personalized arm, we would give additional 3 injections to see whether we could chase down and close those polyps. So essentially, vision was good comparing the personalized treat and extend versus the regular treatment arm. But I draw your attention to the polyp closure rate. So if you could keep up with this personalized, more intensive treatment with aflibercept 2 milligram, additional 3, you got up to 55% closure rate. So very respectable for the 2 milligram agent itself. And essentially, this was the case in the trial itself. So you had inactive polyps, so polyps still present on the ICGA, but having those additional 3 injections really closed down the polyps very nicely. So I get asked this question a lot: why treat and extend? Why not stop? In a lot of these eyes with scans like this, they look very, very quiet. Why not stop and observe and follow up these patients? So I bring you back to those planet cases I showed you, planet patient 1, 2, and 3. So remember, they all did very well in the trial. They all did extremely well at the end of the trial. Look at patient number 1. So ended the trial in 2016, 6/9 vision. And because he did so well, he refused to have any treatment. Came back in 2017 with worsening vision, new hemorrhage. At this point, we had to give him a PDT rescue treatment and had repeated injections and PDTs. And essentially, by 2020, developed a large scar. So 6 years, this was one of our 6-year follow-up planet patients. And from the end of the trial with 6/9 vision, 4 years later in 2020, because of that gap, because of that stop, ended up with a large scar. Let's look at the second patient I showed you just now, doing very well again at the 1-year mark, 6/7.5 vision, exited, declined for the follow-up study, and again came back 3 years later with a very large submacular hemorrhage. In this case here, we managed to rescue his eye with 6 additional Eylea injections and got 6/12 vision. And if you look at our third planet patient, so here again, remember he gained some good vision. And in this particular case here, he decided to stick with a treat and extend, went up to 10-week injections and still maintained that good vision. So 6/9 to 6/9, 3-4 years after the end of the trial. One last patient here. So again, with keeping up with his treat and extend, was able to go up to 12 weeks, again, respectable 6/15 vision. So at the end of an intensive period of treatment, 2 years on a trial, reasonable to start your treat and extend. And back in the day when we were talking about treat and extend 2 weekly intervals, we didn't dare to go beyond 12, 14, 16 weeks. But I believe a lot of these patients can go out to much longer intervals. So remember that aflibercept 2 milligram as an agent has probably the longest, most illustrious amount of clinical evidence, both in terms of randomized control trial, real-world outcomes, and your own personal experience as well, because it's an agent that's been working very well for us and it's been working very well for a long time for many of us. I probably have not seen any serious adverse events with using 2 milligram, and now using 8 milligram, I haven't seen any adverse reactions as well. I can't speak for brolucizumab because I don't use it. I've probably seen 1 or 2 IOIs in faricimab, not major, but there's still something there. So in terms of safety as well, aflibercept, both 2 and 8 milligram have been extremely safe in my hands. So perhaps it's worthwhile to talk a little bit about some new therapies that are coming up. And really the buzzword is about durability. So many of you have heard about TKIs, heard about gene therapy. And of course, new or not so new therapies like 8 milligram are in the market. And in many places we're using, put up a quick slide here, essentially, just as an illustration of what new agents are coming to market. So I snuck in some of these slides. Bayer won't let me put in 8 milligram cases, but I snuck them in. So I just wanted to give a little bit of flavor of what the 8 milligram cases that I've treated with are looking like. So in many cases, again, when a new drug comes, we're always tempted to treat cases that we have treated before that are difficult to treat. So in this particular case here, 2 milligram, 3 loading doses. And after loading, you see doing very, very well as expected with 2 milligram agent. Unfortunately, during extension, 8-week extension, this patient here developed a new cluster of polyps just inferior. So you notice in baseline, the polyp was much more foveal. 8-week extension, you see that the polyps are a little bit outside of the fovea. Patient didn't want to have a shortened interval with 2 milligram because she said, look, I'm doing well. My vision is good. Why are you telling me you need to shorten my interval? So essentially, because I had my hands on some 8 milligram, I gave 8 milligrams for this patient, and you can see a marked reduction in the new area of polyps inferiorly. And on ICGA, those polyps have gone away as well. This is my favorite case because this is my first 8 milligram case. So polypoidal lesion, this patient here had probably about, I don't know, more than 6 aflibercept. It was probably 12 aflibercept, 2 milligrams. And that's what he looked like after all those 2 milligram injections. Large PED, polypoidal lesion, still a sliver of subretinal fluid there. Vision hovered about 618, 615. And with 1 8 milligram, you can see that reduction in that PED. To me, in PCV cases, PED is really a key sign because, as I said, with polyps sitting under the RPE, that's where all the activity is going to be. So with 1 8 milligram, you can see a marked reduction in the PED. So one of the bargains I had with this patient was that because you are a first 8 milligram patient, every time you come and see me, you need to have an ICGA. So he agreed. So every 4 weeks that he saw me for the loading 8 milligram, he had an ICGA. I really wanted to track how that polyp was doing over time, every month. So he had repeated monthly ICGAs, vision improved, anatomy improved, polyp started to get smaller, and eventually the polyp actually regressed after the 4th aflibercept 8 milligram injection. You can see here a quick summary of what happened to this patient. So, sorry. Okay, let's go back one. Okay, anyway, so there we go. So essentially the ICG showing better response up to the 4th injection. And in this particular case here, we managed to do some three-dimensional reconstruction of this polyp. You can see that polyp shrinking down very nicely as well on OCTA. Okay, sorry, this is the old case of paradoxical responses. I'm not sure why it is here. Good, but we saw this just now. There we go. I'm done. Thank you very much for your attention.
Are you waiting for thank you slide or?
I was going for the thank you side, but it's
So at the outset, I'm sorry for being late because of some traffic jam. But I'll request Shashina Jha and Vinod and Shailendra to join us on the stage. It will help ease the traffic here also. There's a lot of rush is here. Shift ho jata hai. Shift.
I have a question for you. You have used both 2 milligram and 8 milligram. Have you actually found any difference as far as efficacy, the duration, and the number of injections? Because this drug is not yet launched.
so I tell you that from a quickness to drying perspective, the 8 milligram is much stronger. And I feel it. I don't use 2 milligram anymore. So I have given up using 2 milligram completely. And because the quick drying with the 8 milligram is so strong, it really is, after that first injection, patients see it and I see it. I don't think I have enough time to speak on durability, but I can tell you in the 1 or 2 patients that have got longer intervals, I've managed to even go up to 6 months. In fact, we were just having a conversation. Having a 6-monthly injection doesn't mean that you can stop.
See, ILHD data is still being accumulated. It's not so clear cut. But in any case, it is not available in country. The fact that you did monthly ICGs, you yourself were not very sure whether it's going to have a quick response or not.
Yes.
Because in any case, I think we should start from diagnosis and treatment. From diagnostic point of view, I think a lot of people still feel that ICGA is a must. Although I think still it's the gold standard. You do not get the kind of information we want in PCV on Octa as compared to ICGA. Although from practical point of view, I think clinical picture and OCT do reasonably good. And there have been Indian studies as well as Asia Pacific studies, which says a reasonably good working algorithm you can carry on. I personally would still like to have ICGA wherever possible, wherever possible. So that I think is agreeable with everybody.
I completely agree. ICGA is the gold standard, and you
But
get
from treatment point of view, ultimately, I think what is the goal? What is the goal? Goal is to close the polyp. Goal is not to, like initially you said, vision improvement. I agree is the ultimate patient wants. But if this vision improvement is transient and you never know when it can bleed or exudate, then I think none of these patients who have rebleeds come back to the previous level at all. And therefore, I agree that treat and extend virtually for lifelong. Virtually for life. There's no. I don't know myself. Don't know the answer when to stop. So therefore, I also have a slide when to stop. And I can't answer this, except that wheresoever I have stopped, I have not gained. Patient has lost actually. So I still remember one patient, he recovered 6/6 and somehow did not come, maybe because of my fault or whatever. Today he has 6/60 because we did not pursue the treatment of treat and extend. And treatment observe is not, PRN is not in PCV, you can't do that and you can't do that. So I wanted to have your, this thing clear cut. What is the goal of our treatment?
So, I mean, ultimately, you want to improve patients' quality of life, and that's vision. But I take your point.
Firstly, do you agree that treatment has to be virtually lifelong?
Yes, absolutely for PCV. In any other subtype, maybe you can stop. But in PCV, I think we've all been bitten many times where we stop treatment or patient disappears. They reappear with a huge submacular hemorrhage. And that is preventable. If you could continue treatment and they were on a good extension, 3 injections a year, that is completely preventable.
So you also mentioned that monotherapy is a reasonably good alternative because we in India, as of now, do not have verteporfin PDT.
Yeah.
So therefore, combo is out. Only PDT is not the answer. Only ranibizumab also is not the answer.
Yeah, absolutely.
Because laptop study, there was one laptop study also which compared, but that also is not the answer. The answer is between aflibercept 2 milligram, as Dr. Mishra was saying, vis-a-vis 8 milligram. As of now, we don't have any option, and most of us, anybody using any other drug apart from aflibercept? Anybody apart from aflibercept? Yeah, faricimab. You see, we will come to that because we at our center have had series where we have labeled that talk. I think Avrinder will be presenting. We presented a series also switch, reswitch, and reswitch. Because unfortunately for us, we somehow, because of faricimab had a promise that it will as if alleviate everything. So we shifted from, we did that mistake or whatever patient also wanted. Because nowadays, because of Google Doctor, everybody wants the latest drug. So we shifted from, Eylea patient were doing pretty well to faricimab, and then we have to shift them back to Eylea. So this response of paradoxical response, you said, I think Avrinder will be presenting 3-4 patients, but we have now at least more than double-digit number of patients where we have shifted to faricimab, but had to get back to Eylea again. So that reason I don't know, but that's perfectly okay. So what do you do in case your patient does not respond to Eylea?
Does not respond to.
Does not. It's not a panacea that it has to respond.
Switch to 8 milligram.
2 milligram first.
2 milligrams. Switch to 8 milligram.
What is the message for us? Suppose it does not respond to 2 milligram.
Well, yeah, of course you can try. Well, you know what? You guys have the advantage of using brolucizumab. So use it carefully.
I'll ask the panelist.
Use it carefully.
So what do you do? The one line answer. What do you do is suppose the patient does not respond to monotherapy. We are not discussing PDT. We are not discussing 8 milligram. Suppose your patient unfortunately does not respond to 2 milligram loading dose.
Very rarely happens that patient does not respond at all. There is some
So in
response.
your-
You can say it is suboptimal, but usually by and large after 3 monthly injections, most of the patients do respond. And then if it does not respond, we have the option of going to brolucizumab.
Yes, Shailendra. One line.
Brolucizumab.
Shashi?
I don't use botensilimab.
So what do you do? Question was not this.
I'll continue with Eylea. Continue with Eylea.
Continue.
I had one question with you. See, as Online Burma has highlighted, it is a lifelong treatment, and we are a very pricey market in India. So, what is the maximum interval we can take in treat and extend to reduce the number of injections in
12 to
PCV?
16 weeks. 12 to 16 weeks.
So with 2 milligram, I believe you get 16 weeks. I'll tell you something quite interesting. So if you look at the new data from Ocular Therapeutics, so this is the TKI phase 3 study, right?
Yeah.
So TKI, their gold standard was aflibercept 2 milligram. The trial was designed with 3 loading doses, and then you were then given a TKI or the aflibercept, and you waited 6 months. The endpoint was loss in 3 lines of vision, right? Your
I think that should not be used nowadays, because you see that 3 lines of vision was started when
Absolutely.
PDT came.
Absolutely.
And today, once we talk of
Absolutely.
graph going up, we should not use the same
So,
criteria.
I would like to make the point about your question about durability. So while the endpoint was 3 lines loss of vision, TKI showed 70% patients didn't have the 3-line loss. Aflibercept 2 milligram showed 53% didn't have the 3-line loss. So 2 milligram was able to go to 6 months in 53% of patients. So it doesn't reflect what the longest
Honestly,
interval
it's
is.
not a great
right?
data.
But-
But 53%, 6-line, 3-line loss. Yes, Vinod.
I think, sir, that's personal experience, because the kind of patients we get in different scenarios, it might differ. I wanted to ask 2-3 questions. So first question, you yourself were part of the group, APOIS guidelines. So how commonly do you look at on-fast OCTs when you are dealing with patients of PCV? I understand you do lots of angiographies, ICGs.
I look at them all the time because I do a lot of imaging. So I might not be reflective of what a standard retinal practice might be, but you can get an on-fast OCTA on almost all platforms, right? You just have to have a dense enough scan on your Heidelberg, on your Zeiss machines to get that on-fast view. So it's there. It's buried in one of the buttons to push to see the on-fast. And that gives you a lot of data. Gives you a lot of data about the branching vascular network, gives you a lot of data about the polyp.
And second question is, we've been talking, I understand, about monotherapy, but is there any scenario where you start with combination therapy because you have PDT?
No, I
never
don't
s-
anymore. I
You know,
give
suppose I'm telling you honestly, in case I had PDT, I will always have POM. Always. Because believe me, it has a lot of advantages. We do not use full fluence PDT. Whenever we had PDT, there were days when 4 PDTs were done, but always low fluence PDT to prevent, choroidal atrophy and ischemia of the choroid and other things. Because we also don't want loss of vision also. Because if you use low fluence PDT along with Eylea, it definitely cuts down on number of injections.
So any specific reason why don't you use PDT at the beginning?
So I think I always want to give it a chance to for anti-VEGF to work. So anti-VEGF in some cases will close off the polyps very nicely, and you may not need to do PDT, which is destructive, right? And you shut down vessels and things.
Second question, do you ever do focal laser to the thermal laser to the
Yeah,
polyps?
I
How
do.
commonly? What percentage of your cases?
Extrafoveal, obviously.
Yeah, extrafoveal, of course.
Always
Always,
maybe
I
about a
think.
third.
About a third.
The trouble with focal laser extrafoveal is if you shut down the polyp on one end, it tends to pop up somewhere else. And your branching vascular network is sitting in the middle of your fovea, it may pop up, it moves from an extrafoveal lesion to a parafoveal lesion, then you run into trouble.
But
So
I think
can I ask
still
a
all
question?
laser, if I have extrafoveal, even if it shows pops up there, I'll still not do a chalky white, but definitely ablate that area.
Absolutely. I don't make the chalky white
No,
anymore.
not chalky
Yeah,
white,
yeah,
but I'll
yeah.
ablate that area.
Yes, yes.
Dr. Lalit, can we ask a question to Dr. Kilvin?
Yeah, sure. Please.
Yeah, so hi. You showed some very interesting data on your personalized treatment that the polyp closure at 2 years was 20% and at 6 years was almost 70%. And then you showed some other data that it closed almost 55% at 6 years. Does it mean that polyp closure with the continued treatment is an incremental response?
Sorry, say that again.
So you said 20% polyp closure at 2 years.
Yep.
And 70% polyp closure at 6 years. which means that these patients who had
He said
polyp
by the
closure.
time
So,
it
so
does it.
that means the polyps did not close and you continued giving them and the polyps eventually closed at 6. Does it mean the polyp closure is an incremental response?
You're asking whether they can reopen and they can
No, no.
close?
So see,
No.
No, what he's saying is with time, the
time.
proportion of patients
Yep.
who have closure increase.
Well, yes, in that 6-year follow-up with Planet, it showed that over time it closed. I suspect it's because in those group of patients, they were probably treated maybe much more closely or much more carefully. Remember with long-term data, and I didn't show the number of patients that were retained for the 6 years was only a small percentage.
Ajay, in any case, none of the pharmacotherapy can ever close the polyp. They can make it dumb, they can make it inactive, they can make it numb, but
But
cannot.
here
If
showing
it closes, it has to be natural history. It
Yeah,
cannot.
so what I
You
would
see,
say, maybe
aflibercept or
maybe the pharmacotherapy is helping the natural history for the
That's
polyps
okay.
to close.
That I
So
don't think
once-
anybody can answer that.
Once your polyp has closed, do you think of stopping the treatment?
Yeah, that's a good
No,
question.
because they reopen.
No, that's okay. So
Yeah,
do you
yeah,
try
yeah.
to tell the patient, look, I'm
No,
stopping
what
the
is the answer to
treatment?
the question? If the polyp has closed on ICGA, do you stop?
No, I don't. I
Answer
will
is no.
continue to treat.
That's what.
That's
Yeah.
what, therefore, I told very bluntly in the beginning that it's a lifelong treatment.
Yes.
You can extend the interval based on your experience or whatever.
So you can't tell the patient that, look, I'm looking for polyp closure, because once you've had the polyp closure, he'll
Yes.
say, look, you told me polyp closure, polyps have closed, now stop the treatment.
But with polyp closure, you have a lower risk of having bad things like submacular hemorrhage. So it reduces your risk of very blinding complication of PCV. So
Achha, Kelvin, I know this is the ILIA sponsored this thing, but
Yes.
have you ever, once you have shifted from ILIA 2 to 8 or 2 to faricimab you showed,
yes,
did you ever forget about the 8 milligram?
yes,
We are talking of 2 milligram to faricimab.
yes,
Have you benefited anytime?
yes, of course,
Mhm.
of course. You have a variety of responses when you treat this in enough numbers.
So your first choice is, suppose you have less response or as Vinod was saying, in a poor response, you prefer drug is 8 milligram or faricimab, if you have experience of both.
So I tell you that my preference is 8 milligram because I believe that these are very VEGF heavy diseases. And if you look at PCV itself, the suboptimal response often is a sprout of new vessels. And sprout of new vessels are always VEGF sensitive. So if you are thinking of it just in terms of amount of VEGF you're throwing into the eye, you want to throw the most amount of VEGF with an agent that has the strongest binding affinity. So from a biological point of view, I might not have the correct answer here, but from a logical point of view, I want to throw the most number of anti-VEGF that I can at this.
So there are some couple of responses from the audience that they would like to shift to faricimab. So any reaction?
I fact that there's not enough response with ILIA. You don't have access to 8 mg in India. And I have had to shift back to ILIA in several patients like the way.
Yeah.
But I do have patients who have responded.
Yeah, I agree. That I agree. I'm not saying that it's a zero response, but the kind of yeah, but you see, if I analyze my data, whenever I shifted from 2 milligram to either faricimab or to brolucimab, I've been happier with brolucimab rather than faricimab.
Actual follow for treated extent. That if the patients become okay.
So, yeah.
Where is the point to say, let's give you the next injection? Because that's also a point to explaining to a patient that you're fine. Every patient can read the OCT now.
Yes.
You don't need to.
Yes.
It's no mystical subject.
Yes.
To OCT.
So a very standard way of looking at it is to do your 2 steps up to 12 weeks, and you can even go to 16 weeks. But what I do is I actually use the early response. So after the first or second injection, it really tells me whether I can go with a big step. So if you get excellent response out of the first or second injection, you can take 4-week steps. I take 4-week steps to get to 16 weeks very, very quickly. And with 8 milligram of faricimab, I am more brave to go to 16, 20, even 24 weeks with the newer drugs.
firstly, your initial protocol for the 2 mg is 3 months.
Yes. Yes.
Right. So now you've got great response.
Yes.
Everything is fine.
Yes.
Are you calling the patient back, let's say now 8 weeks later or 6 weeks later, following him up with OCD?
Yes.
OCD shows nothing now.
Yes.
You still give the injection or you hold on, you just wait till
It is my preference to still give the injection, to be proactive in treatment. Yeah.
A reasonably standard protocol. Most of the international people agree for to an extent is a reasonably standard protocol. Anybody wants to ask one question?
I just want to contribute one fact which you asked about aflibercept. I do not know, Kelvin, if you have tried. Since 2 milligrams is not available in India, and if the patient doesn't respond,
8 milligrams.
8 mil is not available. I have done double dosing of aflibercept, it has worked. So rather than giving 2 milligrams, 4 milligrams.
Happy news will come this year only, don't worry. Yes. Mike,
Very nice presentation. I just had one question that you mentioned that with the hope of closure of the polyps, you increase the intensity of the treatment. Now, what exactly do you mean by that?
So I essentially reload. I give another 3 injections, regardless of what their disease activity is. So after the first 3 loading injections, I do an ICG. If the polyp is still present, I give 3 more injections. So regardless of fluid, no fluid, whatever, I give the 3 more injections.
Manisha, but every month ICG kar rahe ho.
Well, you don't have to do every month ICG. Just
yes. Any one or two last question? Yes. We have 2 more speakers also. Mike, सीधा रखो. Vertical.
That risk is theoretical. Okay, that risk is theoretical. I understand that in some, well, I wasn't here, I was in Malaysia, I think, that there was potential some litigation issues about giving not ranibizumab essentially for stroke patients. But I think that risk is completely theoretical. I don't think that there is enough systemic absorption of that amount that we give in a privileged eye level to cause any issues. I still give aflibercept.
The maximum systemic absorption occurs with ranibizumab, not with aflibercept. नहीं वो तो वैसे भी ना स्ट्रोक यू कांट वेट लाइफ लॉन्ग ऑल्सो ना स्ट्रोक का तो 6 months 3 months हो गया उसके बाद ranibizumab भी दे देते हैं 0.3 milligram we give even ranibizumab also can be given after 3 suppose I have stroke and 3-4 महीने 5 महीने हो गए तो you can give ranibizumab also ऐसी बात नहीं है aflibercept is safer from that. Anybody else or we'll shift to the next presentation. Next presentation I think we have Dr. Charu specifically about aflibercept durability in PCV. And this will be moderated by Dr. Ajay. Ajay, you can join us. You please, thank you so much, and claps for Kelvin. Specifically Kelvin for clearing a lot of doubts in our minds. Even if you strengthen that, it becomes very good for us. So Ajay, you can please join here. No, please, you have to moderate this.
Okay. Good evening, everybody, and thanks, Dr. Teo, for an amazing talk. And well, you made my life very easy. So, well, talking of evaluating durability, I think we always come to the question, why do we want to diagnose PCV? Is I think most importantly, we realize that it has a very good visual prognosis if we diagnose it correctly and if we treat it in time. And of course, we don't really, unfortunately, we don't have Indian statistics. I think that's what we really need to work out. I think there's just one very small study from SN which says around 10%, but I'm sure we in our practice see it a lot more. So of course, it has a lot of varied presentations that we see. So that's something, that always highlights that we need to look for a PCV when we see a large hemorrhage, when we see exudation, when we see something like a PHCR. And of course, ICG is the gold standard. So you can have polyps which are macular, you can have polyps which are peripapillary area, you can have extrafoveal polyps, and you can have polyps in the peripheral on the ultrawide field angiography. But I think the most interesting thing what makes PCV is that you have a neovascular network and you have some polyps. And this is a patient whom we followed up on ICG in 2020. There were some polyps superiorly. 2024, you see the polyps are in a different area. They're temporally. And then further after 2026. So that it is a relentless disease. And that's exactly what we were discussing, is that it can become inactive, but then it becomes active at some other, either some of them reopen or some new ones develop. So of course, ICG is the gold standard, but I think as we've already gone through this, I think these were the two landmark papers, I think, which Dr. Teo has been a part of, which helped us, to diagnose and then gave us the guidelines. So as mentioned, but I think just showing those OCT features, again, you have the sharp peak PED, which is one of the major features. Then you have the RP elevation on the NFAS. I think with OCTA now that we do so often, I think this is one thing we should always look for, and it gives us a very good clue that there is a polyp in that area. The third is, of course, the hyperreflective lesion under the RP. And then there are the minor criteria, the double layer sign, the dilated choroidal vessels. I think all those three major criteria get us to nearly 90% of diagnosis. But I think if we do a multimodal imaging, of course, there's no doubt. So this is a patient, of course, a polypoidal lesion with a sharp peak PED. You have the RP elevation on the NFAS. You have the ICG showing the polyp and the branching neovascular network. But I think coming on to the OCTA, that is, I think as we're going ahead and we're learning more and more, it does show and does help us pick up the lesion. And of course, the cross-sectional OCT with, of course, this is a very good polypoidal lesion that you see with the branching neovascular network. And if you see the cross-sectional OCT, you see the flow area, and that kind of clinches the diagnosis that this is a PCV patient. Of course, the management, as we've gone through, of course, the Everest trial did tell us that PDT with ranibizumab achieved better visual recovery and polyp closure. And we in India, we did follow the same pattern. So this is again a patient, that same patient who underwent PDT with anti-VEGF and 6 months later did very well. The ICG is showing the polyp closure, the OCT is flat. But I think the SNEC study, I think again, which Dr. Teo was a part of, they have also recently studied that how aflibercept kind of compares to with or without reduced fluence PDT does in the present scenario. And they did find that visually, of course, there's not much difference between the two, but definitely the polyp closure rate is much higher. It's 73% compared to 46%. So this is important, but unfortunately, we don't have PDT at the present moment. So of course, the newer anti-VEGFs, which show good visual results and polyp closure or inactivation, are the preferred modality at the present moment. So this is of course, since that is what is available. So this is a good treatment naive patient. And again, you can see the hyperreflective lesion under the RP. You can see on the cross-sectional OCTA, the flow, and you can see the network also on the blue circle. And of course, the ICG showing the polyps. And we did monotherapy in this patient and responded very well to monotherapy. So this is the ICG pre, and this is the ICG post. So of course, the PLANET study did show us that that aflibercept 2 mg monotherapy had non-inferior visual outcomes compared with combination therapy with PDT. And to date, aflibercept is possibly the only molecule to have demonstrated this. So of course, the ICG guide, the APVRS guidelines did tell us how the OCT helps us to diagnose, how multimodal imaging is even better than just OCT, and how the initial treatment is, of course, either combination therapy or anti-VEGF monotherapy. But how do we assess our response? I think that's what we next come to. So we've always talked of diagnosis. Now we come to how to assess the response. But what are we going to assess? Of course, either we're assessing for complete polypoidal regression or incomplete polypoidal regression or PL closure status. So of course, the APVRS did tell us that you treat if an active PCV if there is a new onset of symptoms such as of neovascularization of this fluid, of this hemorrhage or hard exudates at the macula. But how, on looking at the OCT, can you say if the polypoidal lesion has regressed or not? So there's a good paper by the Thai group which tells us the regression pattern on the OCT. So this is how they've defined the 5 pre-specified OCTA features that are there, which I evaluated. So if you see on type A, which is recently, it's basically, it's flattened, the PED is flattened. If you see B, it is showing the bun sign, which so the A and B show that the polyp has possibly regressed. The C is with a minimal bun sign, and the D is with both the hyporeflective and the hyperreflective, and that shows that it is still active. So actually, definitely an ICG is more definitive, but this gives us a good idea as to whether the polyp is inactive or it has closed. So this is a follow-up patient of ours on OCT and OCTA. So he first received 3 Eylea injections or was on Eylea monotherapy. And you see that the polyp it's a type C, that is, you still have a minimal bun side only, and you still have some flow persisting. But I think we did add, since it was an extra focal, we added focal laser. And here you see that the polyp has closed very well. The flow pattern has disappeared. And the same patient 1 year down the line is doing very well and has a type A regression pattern. So actually these patterns do help us to follow up a patient. So coming on to the treatment, of course, subfoveal, this is a subfoveal PCV. You see 2 polypoidal lesions that I say, and then it's just to mark out how these 2 lesions will behave. So after the post-loading dose, you realize that the top one, the yellow one, has not disappeared, but it's become like a neovascular. So instead of the convoluted network, you now just have a neovascular network in that area, and it's a type B kind of a regression pattern. While the lower one, it's closed. So of course, I'm not saying that we are going to stop treatment, but this just helps us to monitor the regression pattern. So this patient, of course, after 3, this is how we showed, after 3 injections is doing very well. We waited for 4 weeks after the 3, but we realized that the lesion is increasing. And then we went back to 6 weeks, and we continued the patient on 6 weeks. And then once it had reached this level, we decided again to extended it to 10 weeks, and lo and behold, it comes back. So then we went back, shortened the interval. So I think that's again what we just discussed, is that a lot of these PCV patients, we can plan extension, but we need to be ready to go back to treating more frequently when they reactivate. So how do we extend patient? I think that we've already discussed. So this is not just to discuss another patient of subfoveal PCV. Again, this received baseline 3 Eylea injections, did not do too well. So we decided to switch up front. I think that was exactly the time Vabysmo came in, but we did not get a paradoxical response. I think this patient did pretty well with Vabysmo. And but of course, when we tried to extend, it did recur. So, and then when it recurred, we again checked the ICG at that point of time, and you realize that, well, there is no polyp closure, it's just polyp inactivation. And that's again one of the problems that we have while treating PCV patients, is that I think we need to be ready for a long term. Of course, unless we have PDT, probably that would have helped. So interestingly, there's another situation, the multilobulated PED with cluster of polypoidal lesions. I think what we realized is this patient we treated many years back, that is 5 years back with PDT, did very well. But of course, PDT was not available. And when this came back with a recurrence, we switched to Paginax, we switched to Vabysmo, but nothing worked. And then there's a very interesting article by the Thai group, which says that persistent fluid is more in case of multilobulated PED on OCT and larger PCV signs, so PCV lesions. So whenever you have a larger PCV lesion on ICGA, I think it's important to tell the patient that possibly the prognosis is not as good, unlike the smaller lesions. So I think coming on to the guidelines, whenever you monitor treatment response with the OCT and ICGA, if there's complete regression and stabilize, you can extend. If there's persistent, then you cannot extend. You just shorten the interval with treat and extend regimen, or you switch to another anti-VEGF agent. And if you have PDT, you add PDT. Of course, very often you have these extrafoveal lesions. This is an extrafoveal polypoidal lesion in the peripapillary area. We did a focal laser with loading dose of Eylea, and this patient has done actually very well. The ICG has shown a total regression, and he's stable for over 3 years. Of course, we are monitoring this patient every 3 months on OCT and OCTA, but luckily we've not required to repeat this patient. This is a last November 2025. So this is another patient with, large extrafoveal polyps. We like to do laser to a lot of these extrafoveal polypoidal lesions with anti-VEGF, and it's shown good sustained response at 1 year, and this is after 5 years. Of course, every 6 months or so, this patient does require a repeat injection. We've also tried to do an image J tracking of the BNN extent, and we've seen that whenever it extends beyond a certain point, or the octa increases, the network, maybe that can give us a clue as to how frequently you need to treat it. This is one of our papers. So of course, when you come on to a subretinal heme, you first have to displace it with TPA gas, and of course then carry on the treatment. So I think in a nutshell, I would just like to summarize that I think it's important to diagnose the variation. The second generation anti-VEGF agents definitely work better. Persistent pays, you have to treat and extend, works very well, and you need to keep treating. Switching is always an option, but adding focal laser to extrafoveal polypoidal extension is a very good and viable option. Thank you.
So as usual, wonderful presentations. I have few questions, and after that I'll put it to the panel. It's always intriguing to me whenever we say that the posology of the drug is 60 days or 62 days for Eylea. And we say we give monthly injections and then we extend it. What actually happens at the molecular level when we extend it? This is a question to you as well as Kelvin, that we are giving the injection, it has a particular molar concentration. Whenever the studies which have been done for 8 milligrams, either for DME or pulsar or photon studies, what they say is they compare it with 2 milligrams of aflibercept. That is the gold standard. And they say that basically why 8 milligram works, it works because the molar concentration is increased. The half-life doesn't change. The half-life of aflibercept 2 milligram and half-life of aflibercept 8 milligram is same. Then what exactly is happening? I have never been able to answer this question to myself. Anybody has an answer?
Yeah, I think so I think initially the half-life does, I think most of what I seem to.
Half-life is 9 days, 11 days, but it works for.
Aflibercept is a little longer. It's, I think, nearly 30 days or.
The half-life for aflibercept is 9
longer.
to 11
longest.
days.
Aflibercept has the longest half-life. I don't remember the
Now
exact.
8 milligram also has the same half-life.
No. So I think what happens is, of course, the drug is in the system. I think it's acting in the system. Initially, what happens is the vessels shrink, right?
No,
So
when you say half-life is this
I
much,
think
what
it takes
happens?
a little. Just 1 second. I think what happens is when we give a drug, the vessels shrink, and then for it to come back to its original it takes a longer time. So it's not that I think the activity has happened initially itself, but for it to come. No, I mean, that's why the reactivation can be, I think that's what he's asking, that why the reactivation happens much later.
He's saying posology says 8 weeks, whereas half-life is 9 to 11 days. This is something to do with pharmaco.
No, that's what I'm saying. What happens?
So my understanding to this is the binding of the drug. What we test half-life is the circulation part. We have no ways of testing how much drug is bound to the VEGF, and that probably works. Is that the answer? I don't know.
The concept of PKPD is how much of the drug is left and how much of the drug is affecting the disease itself, right? So you are right that there's binding affinity. If it's bound to VEGF, it's bound to VEGF. You can't tell how much of it is there. But it has also, as Dr. Charu has said, it has also addressed the disease itself. And addressing the disease, however long for it to come back to reactivate, nobody knows. And that's why you get the 8 weeks or 12 weeks or 16 weeks.
So the vessels will take probably that much long, and how much time it takes to come back, that is the difference in the response. Like some it may come back within 3 weeks, so some it may come back in 1 week, some it may come back in 6 months. So that's how the effective thing has removed.
Okay. Yeah, so when you showed beautiful data on the cross-sectional OCT and you showed the regression patterns, in your practice, when you do you always do a cross-sectional OCT with
That's part and parcel of
with flow patterns?
No, so when you take a section, the
You look at the flow
cross-sectional, okay,
pattern.
yeah, it's part of it. So it comes.
Sir,
So last slide was quite, this thing informative. You said second generation works better. So why shouldn't you start with second generation always?
Why should we start?
Why shouldn't you start with second generation?
No, because we know it definitely works better. I think all the studies have shown that the polyp.
No, I'm talking of the second generation drugs. You start with faricimab.
You can start with any of them. I mean, you can start with aflibercept, faricimab, and your brolucizumab are all second generation. And while their ranibizumab is your first generation, and bevacizumab. So I think this.
Aflibercept to first generation ka hi hai.
So these three, you can start with either of these three. My thing is that don't try and start with the first generation once you know there's a diagnosis of PCV.
No, I don't think so. Anybody starts with ranibizumab. I do not think in PCV nobody starts with ranibizumab. Mostly.
It was just a statement.
Yeah.
Did you experience RIP anytime?
No, actually, I've never seen a RIP in a
Is
PCV
it,
patient.
I think I can ask you this question. Has the RIP gone down with the use of the aflibercept as compared to ranibizumab? Or the reason is something different?
I think the reason is something different. I think the type of PED.
Because you see most the RP, basically the height of the RP was supposed to be the risk factor and all that. And in polyps, you have a very, say, high RP.
Charu is right. We used to see RIPs reasonably frequently. Now, haven't seen for very long.
I've never seen a RIP in a PCV patient. I've seen it, and I see so many RIPs in patients with choroidal clefts and RAP lesions, and those are the patients I see RIPs.
Kelvin, your experience with RIPs?
My hypothesis to this is actually PCV patients are a bit younger. Younger. So your RPE is actually stronger. And your very grotty type 1 AMD, large PED, the RPs are weaker, they're thinner, they're grottier, right? So those are, I think, at more risk of ripping than your polyps who are a bit younger. That's my hypothesis.
Charu, I was waiting for the durability part, enhancing durability.
Well, actually,
how do you enhance the durability?
Sorry? I think my way of enhancing durability is there is if there's a extrafoveal polyp, do a laser treatment, focal laser treatment.
That's a definitive.
Yeah.
The other point I wanted from everybody was we haven't touched anything. We are talking of posterior pole disease. There's a variant of PSCR, which is underdiagnosed entity. Any way that you manage separate differently?
So again, the focal laser is very helpful. So you do a good ICG, you do an ICG, you try and find the area. Of course, give anti-VEGF. And so if there's a lot of exudation, first give the anti-VEGF, get down the exudation, and then do focal laser. If you can do focal laser initially, do focal laser with the anti-VEGF. But they respond very well to.
They respond.
Focal laser in any patient, you showed focal laser in your patients. So you attempt focal laser after giving the injection?
No, I normally do. So that's why I said, if there's a lot of exudation in this area, yes, I will bring down the exudation. But if not, I would just do simultaneously both things together.
Okay. So this answer to your first question. So it's like augmentin 625 is TDS, 1000 milligram is BD. So half-life remains the same, but the amount of drug which remains there increases. So the minimum concentration which is required, that stays for a longer period of time, and that's the reason why.
So it's a molar concentration. Same thing with brolucizumab. Brolucizumab actually has a shorter half-life, but it stays for a longer time because of the higher molar concentration.
Yeah.
And why I wanted to drive home a point was aflibercept has got the greatest binding capacity as compared to the other drugs. Therefore, with 8 milligrams, you are able to increase it to about 12 weeks or 16 weeks. And what Altair studies showed, even with 2 milligrams, you could increase it to a much longer time.
I think as of now, in today's scenario, we should be talking about one is safety. So safety, I think aflibercept, there's no parallel drug. There's no parallel safety as compared to aflibercept. That is number one. Second, what we are looking is for the durability. Now, that is the reason why we are going to mostly to generation 2 or second generation anti-VEGF. Now, it is well established. The problem is that brolucizumab is associated with the IOS. So we don't like to use when it is a good vision patient, 6/9 patient, So it's very difficult to use brolucizumab in such a patient. So faricimab is a good alternative, but again, the kind of durability we would like to see from faricimab, it has not given us practically. So that is
the only
reason
issue
we are
with
again looking at
faricimab will give durability after you have loaded the patient enough. If you have not, you see, then it requires 3 to 5 injections. Then only do you talk of
agree,
extending to 16 weeks or 20
still,
weeks.
but we were looking is our hopes were up to like what we get with brolucizumab.
I agree with you. See the amount of drying you get. If brolucizumab didn't had the IUI and this thing, that would have been the number first choice world over. In fact, well, that would have been number one. But because of that fear, all of us hesitate to put it as second line or non-responsive patients.
And one thing, I think there are quite a few youngsters here. Just remember in today's scenario, I always tell my patients, if you get 2 to 3 or maybe even 4 injections in a year and you are keeping well, so that is an optimal outcome for PCV treatment in today's scenario. What happens tomorrow, we don't know, but that is how we should look at it.
So how much, I ask both of you, how much importance do you give to the placental growth factor? Because that supposedly is important in cases of PCV. I think which is not covered by any other agents.
Yeah, I guess that's what I said. We know that aflibercept works very well. So that's why I say it's the other way around. You know it works well, so possibly it's the placental growth factor that is acting. But yeah, there's no way we can kind of prove it.
Yeah, I tell you, I think
we
all
have-
this is VEGF driven, right? A lot of it is primarily VEGF driven. So you address that, you address most of the problem.
So may I have one question, sir?
Yes,
So,
yes.
Charu, I think I asked you, but I just wanted an opinion from other panelists. Do we really play around with 2 mg aflibercept in the sense give a higher volume or give it much earlier than 1 month?
I think there have been a lot of studies, you were quoting previously that you have, because Eylea somehow supplies more per
Yes.
this thing. So you have the confidence of giving at least 4 million to दे देते हो उसके अंदर.
But how many of us are really doing that is what I was
You
wanting
have
to ask.
some data in that, na?
We have data.
क्या वो उसमें?
No, is it a higher volume?
In
or
fact,
earlier?
honestly speaking, what we did at Center for Sight, we did not find more efficacy with this. So we did not find
any difference.
We did not find efficacy बढ़ गई है उससे. You see, efficacy wise, to my
have
opinion,
one
is
question.
it does not. Efficacy wise, all
Because
the
we have
second generation
lot
do
of
not show
different
more
crowds.
efficacy.
What is your view on biosimilar aflibercept?
Duration.
Biosimilar.
It is the
I'm not
only thing we are
Any
worried about is
US
duration.
Platform we should know about
I
the
haven't-
efficacy of biosimilars of
And
aflibercept.
now it's
Forget.
Listen,
Later on. Let's finish this third talk because talk is not on biosimilars. We will. At the end of it, because the third speaker, let's pay respect to third speaker also. Now we have hello. One last talk is remaining. Hello. One last talk. 5-10 minutes. So Dr. Avneel Gupta, he'll be telling us about switching in the era of newer anti-VEGF agents. Yeah. I'm going to call Rajiv. You have to hear very attentively.
Good evening, everybody. I'll be talking about switch, that is evaluating the need for change, evidence, and insights in anti-VEGF treatment. यही वाली थी. We have a first generation anti-VEGF and we have second generation anti-VEGF that we have discussed. Although there is no cure, timely treatment can help to achieve neovascular AMD treatment goals for dry macula and improvement in vision. The major challenges in using anti-VEGF treatment is there are significant inter-individual difference in response to an anti-VEGF agent, the availability of multiple anti-VEGF agents with different molecular configuration. So there is currently no consensus onto what anti-VEGF treatment has to be started or what molecule has to be started in different AMD pattern or in different patients. So anti-VEGF treatment can be defined as a primary response and a secondary response. Primary response is after 1 month following 3 loading doses in aflibercept, and secondary response is any time after 4th visit. Secondary responses do not mirror and cannot be predicted from that in the primary phase. The responses can be classified into good, partial, and poor responses depending depending on the morphology and the functional status of the eye. The good response means a decrease in CST by 75% and increase in visual acuity by more than 5 letters. Partial response means reduction in CRT between 25 to 75% and change in visual acuity between 1 to 5 letters. Poor responses less than 25% in change in central retinal thickness and visual acuity change in 0 to 4 letters, and no response means there is no change in central retinal thickness and there is a decrease in vision by 5 letters. So if you have this lower 3 patients with partial response, poor response or non-response, you tend to switch this patient to another VEGF molecule. Before that, we'll go on to what Dr. Ajay Arora was talking about, how different anti-VEGF works. There are 2 VEGF receptors. One is VEGF-R2 and second is VEGF-R1. Once you have an hypoxia or an ischemia, VEGF-A is secreted, which binds to VEGF-R2, which causes inflammation, neovascularization, and retinal vascular leakage and edema. In VEGF-R1, you also have placental growth factor, which binds to VEGF-R1 and causes a similar response of inflammation, neovascularization, and retinal leakage and edema. So what is placental growth factor? It is expressed by multiple cell types under pathological condition, binds to VEGF-R1. Both VEGF-A and PGF decreases the inflammation, and that is one of the reasons why aflibercept works better if you have vision less than 20/40 in diabetic macular edema, because it takes care of both the pathway, that is placental growth factor and anti-VEGF. If you look at the existing molecules here, you can see ranibizumab, brolucizumab, and faricimab binds only to VEGF-A, and the molecule which takes care of placental growth factor is aflibercept. So it works in a dual function to decrease the inflammation and decrease the vascularity, decrease the dilatation of the vessels. Now switching to a newer anti-VEGF agent, in 92% of patients who switch from aflibercept to faricimab discontinued treatment due to insufficient efficacy, and that was given by Katoka et al. 130 eyes previously treated with aflibercept, faricimab Q4 shifted to faricimab. 60% discontinued faricimab. The reason was 92% of patients didn't had any improvement in vision, and 73% patients shift back to aflibercept. Now comes the durability. Why you want to switch one molecule? You think that the other molecule has more durability. So this is a study by Kishi et al. Where they showed that 71% of the patients who switched from aflibercept to faricimab remained less than Q8 interval from baseline, meaning by we could not go beyond Q8 if we are shifting from aflibercept to faricimab. This is an Hara et al. Study. After 3 loading doses, significantly better visual outcomes were observed with aflibercept compared to faricimab. Now we'll look at some of our cases. This is a 56-year-old presented with decreased vision, right eye 15 days. Vision was 6/6 part and left eye was 6/6. If you look at the left eye here, you can see there is a subretinal fluid. And on OCT angio, you can see a nice neovascular complex within shrim here. And we started this patient on ranibizumab. Initially with 4 or 5 ranibizumab, patient stayed stable. There was an waxing weaning effect. But at a time, patient stopped responding to ranibizumab. And then we shifted this patient to Eylea. We initially with Eylea also, the response was very good. Patient became dry, maintained 6/6 vision, and patient had an dropped for 2 months, and he came back with a decreased vision within large pigment epithelial detachment and in subretinal fluid. So at this stage, Vabysmo came. We thought we will shift this patient to Vabysmo. And you can see this is a pre-Vabysmo picture, large pigment epithelial detachment with subretinal fluid. And we also tried to evaluate this patient on fluorescein angiography. You can see here that there is an You can see here on the top left, there is a leakage in this part here, and this is a large pigment epithelial detachment. And we gave Vabysmo. You can see the height of the pigment epithelial detachment increased, the subretinal fluid increased. Actually, there was no response with Vabysmo. So we did an fluorescein angiography to reevaluate what should we do, whole of the panel was asking if the patient does not respond to these 2 drugs, then what next has to be done. You can see this hard exudates here, and over a period of time, there was an subretinal hemorrhage. You can see a blocked fluorescence in these pictures. And we did an OCT-A picture. You can see a nice lobulated pigment epithelial detachment, and you can see a BVN or in this area, you can see a complex of CNVM. So what we did, we went ahead and did a focal laser to this active CNVM. And this is, I did in 25, and till date, this patient is maintaining 6/6 vision. No recurrence has occurred. So combining treatment with anti-VEGF with focal laser, you have achieved a good result. This is a post-laser patient with the OCT angio post-laser. You can see almost dry macula here, and no on OCT A images, you can't see any vascular network. This is another patient, 20/20 vision. 6 intravitreal injections were given from March 23 to March 24, 8 weekly dosing, and patient had a slight amount of subretinal fluid with 20/40 vision. Patient at this time, we thought we should shift this patient to Farsimap, and because of the dual action. And you can see this is pre-Farsimap picture, and this is post-Farsimap picture. The fluid or a SRF increased in this patient. Vision dropped from 20/40 to 20/80. And again, the patient said, I want the same drug, Eylea. And we researched this patient back to Eylea. And 3 loading dose of Eylea, you can see patient returning back to 20/25 vision from 20/80 vision. This is one of my patients, was patient of CNVM with intraretinal cyst. We gave 5 injections of brolucimab. At this time, Farsimab came, and we said he will increase the durability, giving more extension. This patient was on 2 monthly brolucimab. This is a fluorescein angiography pictures of the same patient. New drug, we said he will go on to Farsimab. This is pre-Farsimab picture. You can see there is a subretinal fluid with intraretinal fluid. And we gave injection Farsimab. Actually, within a week, the vision decreased from 20/40 to 2200. And you can see the subretinal fluid has increased, the intraretinal fluid has increased. And this patient said, no, actually this drug has not worked. In my case, my vision has deteriorated. So we shifted back this patient to brolucimab. And patient regained 6/9 vision or 20/40 vision after 2 injections of brolucimab. Coming to diabetic macular edema, 6 months of real-world study with Farsimap in diabetic macular edema has showed limited vision gains. 72% of previously treated eyes were switched from aflibercept to Farsimap. You can also see in this chart the durability has not increased with Farsimap. Almost 80% of the patients were less than Q8. They were not able to go till Q12 or Q16 as claimed by Farsimap people. The real world outcomes of intravitreal Farsimap 6 milligram with aflibercept 2 milligram injection in diabetic macular edema. You can see Farsimap and aflibercept achieve comparable short-term anatomical and functional outcomes. If you compare head-to-head two baseline trials which gave accreditation to aflibercept and Farsimap, if you look at 2 years data in AMD with Tenaya and Lucent, the number of injections were 10 in Tenaya and Lucent. In Altair, it was 10.4. Means the claim of durability ki Farsimap has more durability. Their study also says ki you need 10 injections per year. So where is the claim ki you can extend to 16 weeks or 18 weeks with Farsimap? So you can achieve the same kind of a result with same visual gains. Like in Farsimap, you had a gain of 3.7 and 5 letters, but in aflibercept, you had a gain of 7.6 and 6.1 letter. So the claim of durability is not there if we compare head-to-head their trial with aflibercept trials. If we go on to an diabetic macular edema trials, Yoshimite and Bryant trial, you had 15 injections, and Vivid and Vista with the 2 years, you needed 13.5 injections. And the vision gain were almost 11 letters in both the trials. So again, the claim that you have more durability, that's not, if we compare head-to-head both the trials, that's not there. Ki Farsimap has a greater durability as compared to aflibercept. And so you can, if you want to switch, if patient is not responding, then you can switch, but data does not suggest ki you should start with Farsimap. The results are almost similar. Could targeting additional pathway beyond VEGF, what Farsimap people are saying ki you have two pathways. One is VEGF pathway and second is an ANG2 pathway, which is there with Farsimap. And then what we talked about increasing the molar dose with brolucizumab and PDS with ranibizumab. So there is a drug, what we call as a nesvecumab. It is a specific ANG2 inhibitor. So there was a trial, which is Ruby and Onyx trial, which combined aflibercept with nevacumab, and the results were not superior. Thereby meaning that ANG2 does not have much role in decreasing the inflammation as claimed by Farsimap people. This trial was done till phase 2, and since there was a no superiority effect from aflibercept, so they didn't go on to phase 3 and they stopped this trial at phase 2. Again, with Farsimap, you have ANG2 inhibition, which we have shown that it does not have much of action. You can see the trial Tenaya and Lucent, the visual effects were almost same as aflibercept. If you see FDA approval of Farsimap, what they have written in their FDA approval is the VEGF antigen binding fragment is identical to ranibizumab, that meaning thereby that if you are giving Farsimap, actually you are giving ranibizumab, and ANG2 does not contribute much to inflammation. This is an PAT survey conducted by American Society of Retina Surgeons. In AMD, what is your preferred first line of anti-VEGF for wet AMD if no prior access restrictions? The drug of choice was aflibercept. internationally. And in diabetic macular edema, the drug of choice is again aflibercept in 52% of the patients. So to summarize, with aflibercept 2 milligram already targeting three ligands of master regulator, that is VEGF and PGIF, you are causing a dual pathway inhibition. And if you increase the molar dose, you can achieve more durability with 8 milligrams. Thank you very much.
Avnind, the way with your strength as well as emotional also, you have buried all the claims of Farsimab. Farsimab people, in fact.
I want to add one thing. Dr. Avnind, this was a study which has been, Western population. We have done our study, which is just published in IGO, about the RCT of Farsimab versus aflibercept in diabetic. It is clearly proved that Farsimab works equally well like aflibercept, and the number of injection requirement is lesser in Farsimab. So let us not, because it's not a financial angle to this. We don't have any financial angle to it, but we must also present the correct data which we have found in our study.
So very strong presentation. The way it went, it seemed that there is no choice to switch since we don't have Eylea 8 mg right now. So you keep on giving Eylea, whether the patient responds, it doesn't respond, you don't have a choice. But we have a choice. So
initially,
I just want to know, there must be patients, when you switched, they benefited.
Yeah, there are patients. Actually, one condition where I feel Farsimab is more superior than aflibercept is if you have hard exudates in the macula. And if you give Farsimab, this hard exudate decreases within 2 to 3 weeks. I can show you the photographs. But the main problem is there is no difference in OCT. The OCT difference is almost the same. I have compared at 2 weeks, 4 weeks. The effect is almost similar as in if you have exudation, yes, it works better. Because I used to give steroids in these kind of patients where you had a lot of exudation in diabetic macular edema. I find Farsimab more effective in these.
I think we are digressing that we are not here to compare Farsimab versus this. Our aim was switching in the era of new anti-VEGFs. So where to switch to? Suppose Eylea, we are doing like you gave 3 examples.
So what I showed you, if you have a poor response or a suboptimal response, last 2 conditions, then you need to switch to other molecule.
Other means?
Other molecules are, we have brolucimab and we have Farsimab. My first choice is brolucimab.
So the other questions which comes to our mind is, since a lot of youngsters are also there, after how many injections do you switch? And what is your threshold for subretinal fluid vis-a-vis intraretinal fluid? When you say that the patient is not responding well, now I'll switch. After 2 injections, after 3 injections, you've done the loading dose. Now the 4th injection, the patient comes, there's a lot of swelling, which is almost the same as the last injection. Would you switch or you'll keep on going with the same injection?
See, AMD, I'll go in for a loading dose. Before loading finishes, I will not like to switch in age-related macular degeneration. In diabetic macular edema, my switch is somewhere between 3 OCTs and 2 injections. Means 3 OCTs if it is not responding. After giving 2 injections, I'll say I'll switch on to other molecule.
So I want to put this question to the panel also. When to switch and which agent to switch, let's say PCV versus DME.
DME is a very easy disease to treat because it's a multifactorial disease. You have to pay attention to a lot of other factors. You see, like lipid levels, like hypertension, like sleep apnea, like hemoglobin, like fluorescein angiography pictures, CNP areas, non-perfusion. So DME is, we are not bothered. In fact, if you ask me the question, my threshold for shifting in DME is much earlier because after 2 or 3 injections, I'll shift. And my agent of choice from shifting is to Ozurdex. And I have never, seen patient not responding. When, sir, we have shifted from aflibercept, first line is aflibercept, we give 3 injections, patient not responding, shift to Ozurdex. That is my first line. And in AMD or PCV, my choice of shifting is always to brolucimab. And because actually 8 milligram is not available, and we are waiting, somehow HD milligram comes up. But faricimab, we haven't had such a good response. The only thing I wanted to ask you, AG, was both the patient faricimab, you have given only 1 week. You see,
No,
I personally want that you should have given at least some time. Faricimab is not a molecule which will act in 1 week.
No, sir.
It takes.
I have not given 1 week time. I have done OCTs to see the response at 1 week, 2 weeks, and 4 weeks. Because that was my learning also, what phase I'll get a response with the faricimab. So I have done 3 OCTs for these patients for my learning to see if when does it starts working. And in diabetic macular edema, I do a lot of rescue lasers or to extrafoveal leaks, which works very well in diabetic macular edema.
Yeah, that is true.
So in the meantime, Dr. Teo, what do you switch to once you have a non-responder or a suboptimal response? Because you're already using 8 mg.
So I suppose the question is, what do you mean by suboptimal response, right? So I do switch to 8 milligram if anatomy is looking bad, but yeah, I mean, there is option of faricimab as well, but switching to faricimab doesn't seem to give that same wow. I don't know. All of us would have lived through the era of going from ranibizumab to aflibercept, and that was a big
So
wow.
that wow effect is not there with Vabysmo for all the conditions across all spectrum. It's only after third injection that you realize that patients are
happy. Talk to Vabysmo people, they say ki if you switch, you go on to loading dose again of 4 injections. And on loading, if you don't get a response, then patient is on your head ki there is no response and you have switched to a costlier medicine.
I think the take back is whenever we shift from aflibercept to say faricimab, so it's not uniform that we will get a good response. We get variable responses. Sometimes it works well, sometimes it gives longevity, but that's not always true. On the other hand, we have dealt with brolucizumab, and that has given us uniformly good results. And that's having that said, there is a definitive role of intravitreal steroids when it comes to diabetic macular edema, but the same may not be true in a patient with age-related macular degeneration or PCV.
Yeah. There's one question from the net I am asking because
1 minute.
There's one question the net people are asking.
Okay.
Because it's long. Have you noticed, for you, Kelvin, have you noticed any imaging biomarkers or signal which predict paradoxical worsening of PCV after switching from aflibercept to faricimab?
No, I have not.
This is by Dr. Anand Rajendran.
No, I've not noticed anything. And it's when we first got it, I came a little bit of a surprise, to be honest. And for some reason, the disease never seemed to reactivate at the same spot. It always was somewhere else. That was my experience, at least, but nothing in particular. No.
The second question is that same what Dr. Jha was asking. Is there any increased risk of RP-RIP with aflibercept 8 milligram?
Again, no, not in my experience. I haven't had.
So answer, Anand, is no. Yes, Shashi, continue.
About switching, I think aflibercept to Vabysmo, I think that is settled. On the PCVs, I think the result is so obvious. Brolucizumab, those who are comfortable. My question is to panelists is that about the diabetic macular edema. See, our market is very pricey. And now with the biosimilars have established very well and they become very cheap. So if you have to switch from the aflibercept, I think switch to ranibizumab, where a patient can go for every month injections. In fact, add to the agony of Vabysmo. One patient of DME, I injected Vabysmo, but she didn't respond, and she's responding very well to the biosimilars. So I think the pricing we can switch to, because you need multiple injections in diabetics. You can switch to ranibizumab biosimilars instead of switching to Vabysmo, which is still a fairly costly drug in Indian situation.
It's a huge treatment burden, and I guess the best treatment in my clinic is received by the patients who are CGHS or ECHS or DGHS beneficiaries, because they get as many as injections they can, whatever we advise, they get it done. So, sir, before we'll wrap up this talk, I just want if you can summarize when to switch. You start with Eylea, you give 3 injections, whether there is no response or suboptimal response, you still give 3 injections. Then you switch to alternate drug, and what drug, whether it's Broly or it's Vabysmo.
Yeah, I think this has been discussed 4 or 5 times. This has been discussed. If we had 8 milligram, we would have shifted to 8 milligram. As of now, there is a divided opinion between some people who want to shift to faricimab, some people who want to shift to brolucimab. And brolucimab, we have had good experience, there's no doubt. The only fear remains of IOI, which is fortunately not so prevalent in this part of the world. Although we had one study by VRSI, which Manisha had published, which was 0.79% and not 4%. But there are a lot of good responses people have had with the also. Yes, Ajay.
You had a patient with some of this responding. Do we go to 6 injections a lot of people?
Yeah, so it's when you talk about loading, it's not 3, it's loading until dry. I mean, that was the initial thought of loading injections, right? The idea with 3 is that you are dry after the first and second injection, and you take the third one.
See, Ajay, that Neil Bressler, he poisoned our minds so much at that time, and we are still sticking on. Kelvin, do you agree? Those 6 injections era has gone. No patient today has that patience today that he will wait for 6 injections. Suboptimal response, aayega, kab aayega. I don't think so patient wait for 6 injections.
If they're dry in the second, I extend it.
Yeah. Because that era was only for first generation when we used to hear Bressler and Bressler. I think.
Can I make a small comment?
Yeah.
Having said that, we had a trial phase 4.
This is that some people are late responders.
So for phase 4 for aflibercept, and we actually saw the patient did not respond till 3 injections and started responding in 4th and 5th.
How much percentage?
That percentage was very low, but that phenomenon does happen.
We know that in medicine there's nothing sacrosanct. 100% there's no 100% with any disease. So there will be 5-10%. But as a majority statement, if you have to wait, you should not be saying today in the era of second generation injections coming up, you say we'll wait for 6 injections. Yes.
Sir, I have a small observation.
Give the audience participant better it is.
So I have a few PCV patients, and I was giving Eylea. One patient unfortunately had an end-off, 2 had breakthrough bleeds, and I did vitrectomy in all of them. And somehow after vitrectomy, I have not had to repeat any injection, and the PED has completely flattened. Any comments on that?
Kelvin, your take on this? After vitrectomy, it is flattened.
Yeah, so I think I see that too. If you bleed, it almost bleeds out, and then the lesion is quiet. Yeah. I'm not advocating that you should let them bleed out, but yeah, possibly.
So I think it's time to wind up this session. At the outset, let's thank the Bayer people, the MedEvent people for arranging this wonderful session. And we have had 3 wonderful talks, and our star speaker Kelvin, very thankful to you for traveling all the way and making all of us aware of all these diseases. There were some misconceptions we had, and I think a lot of things have become clear. And just to summarize from diagnostic point of view, a lot of us still pay attention to the clinical picture and the OCT, but people who have multimodal imaging and ICGA, we do tend to do ICGA, especially in patients who are not responding or have poor response to initial. And as far as management is concerned, there are 2 aspects. One is patient has a hemorrhage. We didn't discuss about the patients who present with large